Hello, hello. We are ready to start with the second podcast of the series Not Spital lectures. Yeah! The topic for tonight is fluid therapy principles, and what we're going to cover is just the basics of fluid therapy in terms of how they are classified and how each class of fluid therapy is then approached and what are the principles that they rely on respectively. So fluid resuscitation is always a little bit often exchanged or misinterpreted as an attempt to do a rapid fluid replacement. Fluid resuscitation instead has the goal of restore, by definition, intravascular compartment. So if you think of a water compartments in the body, you're going to have the total body water that is distributed between the extracellular space and the intracellular space. A small fraction of the extracellular space will be the intravascular space. However, intravascular space is just a fraction of what is actually in the total amount of water that is in the body. So we call total body water, and then we're going to have extracellular space, of which a small fraction is the intravascular space. For what regards water and electrolytes, what happens in the intravascular space happens in the extracellular space. So whatever you're doing that is related to small molecules and water, there will be a continued movement and equilibrium between the intravascular and the extracellular space. What happens within the cells instead is very tightly controlled by the cell function. As long as the cell is alive, they will do their best to maintain a steady equilibrium of concentration of electrolytes and amount of water, unless there's an excessive variation of what they can normally handle, normally related to the osmolar gradient between within the cell and outside the cell. And if that gradient is beyond what the cell can overcome by compensatory mechanism, then you're going to have changes. But otherwise, what normally happens within the body is tight control within the cells of what is happening, and then the extracellular space instead is what maintains the equilibrium of everything else, including the intravascular space. So when you resuscitate an animal, by definition, the goal of resuscitation is restoring the intravascular compartment that is deficient. You decide to resuscitate an animal because it has a lack of perfusion or a lack of circulation. Those are the only two reasons for a patient to receive fluid resuscitation. The other reason why you would attempt fluid resuscitation is when you don't know if such a patient with lack of circulation or poor perfusion may be a patient that is considered a fluid responder or not. If you cannot determine on your examination whether he's a fluid responder or not, and in some cases it's extremely hard. There's no really one single parameter that you can use to decide if that patient is fluid responder or not. So given the deficiency or the inability to determine up front whether cardiovascularly or hemodynamically such a patient is a fluid responder or not, what was invented is a big word, but what was then defined is the fluid challenge. The fluid challenge is simply an attempt to restore circulation and perfusion by using a fluid resuscitation and evaluate what response you get from the patient. If you give that bolus to a patient that is hemodynamically unstable and the response is positive, meaning the hemodynamic of the patient is improved, circulation is improved, perfusion is improved, by definition that patient is a fluid responder. If the stability of the patient persists following that bolus, then likely that patient was fully restored for circulation and perfusion. But if he goes back to where he was before, potentially the lack of perfusion is still dependent on more fluid. So you will repeat your fluid bolus because you have determined that the first was very effective at improving, but shortly after it just returned to where it was before. Why did they return to what it was before? Simply because, as I told you, the intravascular space communicates directly with the extracellular space, which is a much wider compartment. So when you optimize the intravascular space, but the extracellular space is still lacking, just like the intravascular, whatever happens immediately after the bolus simply will then be equilibrated with the whatever is outside the intravascular space, and then you will lose the advantage that you just had. What does it mean? That that patient likely needs more resuscitation to optimize circulation and perfusion. So this is a simple way to recognize what kind of response you can get from a patient. The type of responses that you're going to have from a fluid challenge are negative, no change at all. Let's say you have a patient that paradoxically is in congestive heart failure. So he's already hypervolemic and volume overloaded by definition. And you have him hypotensive and you see that he has poor perfusion. You don't recognize, for whatever reason, that that patient is in congestive heart failure, and you give him a bolus of fluid. The outcome of that bolus of fluid obviously will not provide better circulation or perfusion, will actually deteriorate the patient condition without optimization of the circulation. So that is an example of a negative fluid challenge. That by definition is a patient that is not a fluid responder. A fluid response instead that is partial is the patient that you give, that arrives to you in shock, compromised, you give it your fluid challenge, and we'll talk about what are the fluid challenges options that you have, and the response that you have is of an improvement but not optimization. Perfusion remains impaired, capillary fill times remains impaired, the clearance of lactate is not adequate, is only partial, and the mentation doesn't improve, and all the parameters that you're assessing are not indicating that you had control of the lack of circulation, in which case that means that your fluid challenge was partially effective, but that should warrant further resuscitation to achieve a better stabilization. The alternative option is that you have full control by short lasting, as we just mentioned. The ultimate option instead is that you achieve control, full control, and it persists. That means that your fluid challenge was also adequate as a full fluid resuscitation. How do you perform fluid resuscitation? Fluid resuscitation, by definition, as we said, is aimed to expand the intravascular volume and restore circulation. So you'll do fluid resuscitation when you have a patient that has poor circulation and perfusion, so he's in a critical situation, and your goal is the intravascular space. So you'll administer in the shortest amount of time possible. When I say shortest amount of time possible, I mean it. Because if you have, paradoxically, a 10-gauge catheter, and in a CAT, which you'll never have, but if you were able to have it, you would administer that bolus over seconds. Because the goal, again, is expansion of the intravascular space. Normally, because of ease of administration and feasibility of the bolus, is always given over 1 to 2 minutes. Even a 40 kilogram or 50 kilogram San Bernard's that arrives with a gastric dilation bolus, if he has a 16-gauge catheter in his cephalic vein, with a squeeze bag, you'll be able to give him a liter of fluid over 2 minutes. You need to use a squeeze bag. You need to pressurize the gradient to achieve that goal. But an infusion during resuscitation is meaningless because you don't achieve the expansion of the intravascular space to determine if that patient is responsive or not before there's a re-equilibration between the intravascular space and the extracellular space. That's why a bolus that takes 15-20 minutes is no longer fluid resuscitation. It's a fast infusion with the aim of giving some fluid rapidly, but that's not the fluid resuscitation aim that you have in terms of intravascular expansion. Consider that when you use standard means of fluid resuscitation, whether it is crystalloids or colloids, a large fraction of what you administer gets distributed to the extracellular space within 15 minutes. So there was an old dogma that determined that if you resuscitate an animal with crystalloids, balanced or unbalanced crystalloids, if you give a 30 ml per kilo of that, that would equal to 10 ml per kilo of a synthetic colloid, 1 to 3 ratio. So you give a third of the crystalloid dose to achieve the same volume expansion, because relying on the oncotic pressure of the synthetic colloid, you would then drag water from the extravascular space into circulation and expand the intravascular space in the same amount that the amount of crystalloids is. Also, it was said that that would persist over time for a much longer period of time than the crystalloid would. When they actually radio-labeled patients, healthy patients and inflammatory patients, so patients that had endotoxemia but also healthy patients, and they gave the proportions of crystalloids and colloids to determine what was actually the appropriate therapeutic ratio between the two. They determined that 1 liter of head starch does the job of volume expansion of 1.3 liters of normal saline. So the ratio is not 1 to 3, it's 1 to 1.3. And 15 minutes following the administration, they were equal, absolutely equal. That's why this big advantage of giving synthetic colloid, even from a therapeutic standpoint, resuscitation, is nearly meaningless, because you give definitely mostly nearly the same amount to achieve the same goal in volume expansion, and also at 15 minutes they are both distributed outside the vascular space just as much. The more inflamed the patient is, the worse it is, because that, imagine, happens to even plasma protein. The distribution of plasma protein is farly changed and modified by inflammatory condition. A patient that is septic will have up to 80% of the total body albumin, for example, in the extracellular compartment and not intravascularly distributed, because the porosity and the leakage from the capillary in inflammatory condition doesn't allow the retention of fluid intravascularly. The main driver of that is the glycocalyx barrier. The glycocalyx is something that nobody gave a shit, or I shouldn't have said that because it's recorded, but nobody cared about for the longest period of time. But now we have realized that it's not the quality or the integrity of the capillary that determines the fluid shift from compartments, but it's the integrity of the charges, the electrical charges that are present on the glycocalyx. I'm sure that all of you have heard the Starling laws and of distribution of fluids, where hydrostatic pressure and oncotic pressure fight against one another, where the intravascular capillary hydrostatic pressure is the one that pushes fluid outside the cell, outside the vessel, and then the oncotic pressure within the capillary is the one that retains the fluid within the intravascular space. In the interstitium, you also had an hydrostatic pressure that pushes fluid, it keeps it into the intravascular space, but you have an oncotic pressure that drags water out. So this constant fight was determined to be the way fluid shifts from the intravascular compartment to the extravascular compartment. And it was proven not to be true, because what really determines such a shift is the glycocalyx barrier within the capillaries. If the glycocalyx is active, it represents an interface where fluid from the intravascular space to go outside needs to go through. So the pressures that need to be accounted for that shift is between the intravascular space and whatever is below the glycocalyx, but still within the capillary. You need to imagine the adventitial layer of the capillary, the muscularis of the capillary, if it has a muscularis, or simply the cell layer, the endothelium layer, and then above the endothelium, a microscopic space that is a virtual space, and then the glycocalyx, which is this mucoid proteinaceous electrically charged layer, and then the cells that run into the bloodstream along with plasma. The interface that now has been demonstrated to be the one associated to fluid shift is not between within the capillary and the interstitium, but is between the capillary and the virtual layer below the glycocalyx, still within the capillary. The problem is, in inflammatory condition, the glycocalyx is the first thing that disappears. The inflammatory cytokines degrade the glycocalyx, and that's why the capillary becomes leaky, even if the capillary cell layer is still intact. So because of that, the distribution of fluid resuscitation fluid between synthetic colloids versus crystalloids has not shown any difference whatsoever in advantage of one over the other. But we all now know what are potential disadvantages of the synthetic colloid, which is not the reason why we're going to talk about today. So moving forward, how do you resuscitate an animal? Well, that depends on the condition that the animal has. If the patient may require resuscitation because has had a hemorrhage or a blood loss, the best way to resuscitate that patient would be by using blood products. That is called hemostatic resuscitation, especially if the type of blood loss that he has had was due to a controllable hemorrhage. In those cases, blood products are the one that are recommended. In any other circumstances, there was never been demonstrated that using anything but crystalloids, balanced crystalloid, and this is the important aspect that I want to highlight, balanced meaning that they have a constitution of electrolytes that is similar to the one of plasma. For example, a balanced crystalloid is plasmalite A, Ringer lactate, Ringer acetate, whereas an unbalanced crystalloid is 0.9% sodium chloride. Although the osmolarity is nearly the same between those type of fluids, the sodium chloride has a concentration of chloride that is extremely abnormal for physiologic purposes. The chloride in 0.9% sodium chloride is 154 milliequivalents of chloride per liter, as well as 154 milliequivalents of sodium. Now, in the normal animal, 154 milliequivalents of sodium is slightly higher than normal than what it is normal for a dog, and nearly normal for a cat. The chloride, however, in a dog would be somewhere between 100 and 105. In a dog, you bring it up to 110, but still, there's a much significant difference in the amount of chloride that is in the concentration of sodium chloride. What is the issue there? It's not the amount of chloride that you give them, but the fact that given that in sodium chloride, the difference between sodium and chloride in a solution is zero, because sodium chloride has 154 milliequivalents of sodium, 154 milliequivalents of chloride. When you administer that, the gradient between the two affects what happens within the body, because the gradient between the difference in the body of the patient normally is between 145, 150 of sodium minus the 105 or 110 of chloride. Such difference was long kind of ignored for a long time for any type of effect that was systemic. By the Stewart approach to acid-base analysis, we recognize that difference might be the most important drive to induce acidosis versus alkalosis. That gradient is called strong ion difference. The strong ion difference is the most important non-dependent variable in the acid-base analysis that now currently is recognized to be the truth of how acid-base work. For example, bicarbonate is meaningless for acid-base analysis purposes, which was like the driving factor to look at until 10 or 15 years ago. Mistaken, just know that. But this strong ion difference is the strongest determinant of what the fluid that you're administering is going to induce in the body. So, for example, sodium chloride has the same pH in the solution of Ringer lactate, because sodium chloride has a pH between 4.5 and 5.5, normally somewhere around 5. Ringer lactate has a pH of about 5, 5.1, 5.2. So the pH of the solutions is identical. But when you give it to a patient in equal amount, the strong ion difference of sodium chloride is 0, so it will drastically drop the strong ion difference on the patient and induce acidosis, whereas Ringer lactate, not because it's buffered, not because there's lactate in it, that doesn't cause acidosis, because the lactate gets eliminated in a heartbeat, turns into bicarb, and then it gets exhaled as CO2. So it's not that fixes that prevents the acidosis. It's the fact that in Ringer lactate you have 140 milliequivalents of sodium and 105 of chloride. So the gradient between the two is 35. That is still below what is in the body, but much closer to physiologic. That's the difference between a balanced solution, LRS, plasma-like, normal salt R, versus an unbalanced solution. And now we know that balanced solution should be the solution to use for that reason in fluid resuscitation and fluid replacement, and putting aside anything that is high chloride content because of the risk of the hyperchloremia associated acidosis. The ways administered, as I said, is as rapidly as possible, but the next most important thing to be considered is when to reassess the patient. As I said, the goal is to restore circulation and perfusion, to achieve that goal as rapidly as possible, but also to be able to determine whether that patient has benefited from that bolus of fluid and how long that benefit is achieved for. So the assessment of the patient following the rapid bolus that is given needs to be done immediately following the bolus. You reassess perfusion, you reassess mentation, you reassess circulation, you reassess what kind of cardiovascular response you have achieved. If you have a patient that presents to you with hemorrhagic gastroenteritis and has been vomiting and having diarrhea for 2 days, or a parvo puppy, and you decide that he is hypovolemic and his lack of circulation and perfusion, you say, okay, I give him 10 ml per kilo bolus of LRS over 2 minutes. Well, you need to be able to reassess the response that that puppy had immediately after the bolus. Immediately meaning just finished, you reassess pulse quality, you reassess peripheral pulse, you reassess CRT, you reassess the heart rate. Why would the heart rate drop following fluid bolus? Simply, that's his baroreflex. If you improve perfusion, you rise the pressure, the baroreceptors will detect that change in pressure, and as a response, you're going to have a drop in heart rate by parasympathetic response. That's the normal reflex that is built around changes in perfusion pressure. If that perfusion pressure then drops 5 minutes later, your heart rate will start rising again. Your periphery will become constricted. Your capillary refill time will become shorter and shorter, because what happens is that the patient that becomes hypoperfused in the early stages of hypoperfusion will have a compensatory response. That compensatory response shifts blood from the large compartment of the body to a smaller and smaller compartment the more compromised the body is. That shift occurs in any system that is not vital. And that volume that remains in those compartments that is not recruited is called unstressed volume. Is a volume that is there, is a volume of blood and plasma that is available, but that the body is not actively using. The stressed volume instead is the one that the body is trying to recruit as much as it can to maintain circulation of the vital organs, which are heart, lungs, kidneys, and brain. That's all the body tries to do. So it shrinks circulation outside, so the skin gets hypoperfused, the intestine gets hypoperfused, the splanchnic circulations gets hypoperfused, and the mucosa that are not vital are also hypoperfused. That's why your capillary refill time shrinks, because you have tightening of the arterioles sphincters first in response to that. So there's less perfusion. When you put your finger over the mucous membrane, then you see that they refilled over a longer period of time, because there's not enough perfusion to make it adequate. So instead of being 2 seconds, become 3 seconds, 4 seconds, 5 seconds. Okay? You give another bolus, and the refill time returns to 2 seconds, because the capillary now are relaxed, there's better perfusion, and there's more ability for the body to use stress volume to perfuse more areas. The patient might have still blood in the spleen, still blood in the intestine, but he's not recruiting it. To recruit that volume, you might have then to push it even harder and use pressors that will allow you to recruit all that blood that is now sitting there is not helpful. And that's why pressors now, they are becoming more important even in early stages of resuscitation of hypovolemic patients, because we know that we can help the body to become to get a little bit of superpower to recruit such extra volume of blood that is considered unstressed and make it stress volume. The circulation is maintained in the body not by the blood flow, but by the what is called active circulation volume. The active circulation volume is the amount of blood that the heart is able to eject and maintain a perfusing pressure that is adequate to sustain the organic function of each organ. Each organ has a specific perfusion pressure, and the heart is able, when it's functioning normal, to make every organ happy in the body. But if the heart is working poorly, for example, a dog with DCM, dilated cardiomyopathy, will have a very adequate circulating volume. His blood volume actually is higher than he should, because the mechanism of compensation of vasopressin and all the systems that come into place in early stages of DCM actually cause hypervolemia. So his circulating volume and blood volume is much higher than a normal patient. However, the active circulation volume is much lower, because, for example, the renal perfusion is not adequate to maintain normal GFR. And that's why those patients tend to put in place systems that normally would be triggered only in patients that are hypovolemic. For example, retention of free water. The retention of free water is a classic mechanism that we put in place when we are very thirsty and very dehydrated. So antidiuretic hormone kicks in and reabsorbs as much free water from that collecting duct as much as possible. That reabsorption of free water dilutes the total body sodium in the extracellular space, and that's why they become hyponatremic. Those patients that have dilated cardiomyopathy do the same, despite the fact that they are already hypervolemic. That's why, for example, hyponatremia is a negative prognostic factor in a dilated cardiomyopathy dog, because it tells you that the circulation of that patient is so impaired that is perceived by the kidneys as hypoperfused severe enough to simulate hypovolemia. That tells you that the cardiac output of those patients is terrible. And that's why it's turned out to be on the epidemiological studies and signs of negative prognosis. But once again, you need to understand what is the primary goal of the attempt of fluid administration that you have. Once you have in mind the ultimate goal, you can determine how you're going to administer, and then with the knowledge of the studies that have done up to that point, make an educated choice on what to administer. And I think that we're running out of time, so instead of being principle of fluid resuscitation turned out to be, or fluid therapy turned out to be a fluid resuscitation discussion, and I think we're done for today. Thank you very much, and we'll talk again tomorrow. Bye-bye.